This conference will now be recorded.
Okay, well, thank everybody for joining us today. Just to let everyone know before we get started, two things is we are recording this session and it will be shared to you either later today or tomorrow. And the other is please keep yourselves on mute while the presenter is speaking. And if you have any questions or comments, please feel free to use the chat room key function, and I will be monitoring that as Dr. Worshel and Dr. Nelson and Maria Rubio will be chatting with you today. So without further ado, let me introduce you to Dr. Worshel, who's going to talk a little bit about his department, and take it away.
Hi, good afternoon. I'm Dr. Barry Worshel. I'm the Chief of the Division of Gastroenterology, Hepatology, and Nutrition at Lurie Children's. I just want to give you a little bit of an overview of the division. Right now we have 27 faculty members and 11 advanced practice providers, which makes us one of the largest pediatric GI programs in the Midwest. We work out of 12 satellites. The 12th that's going to be added sometime mid-November is going to be a site at Skokie. These various satellite practices are really allowing us to provide the best care possible to the people in Chicagoland. It's also allowed us to move some of our subspecialty programs into these locations that had previously been only available down at Lurie Children's. So now we have a comprehensive IBD program out at Northbrook. And I also wanted to highlight one of our more unique programs, that is the initiation of an integrative medicine program, where one of our faculty has undergone advanced training in various alternative medicine approaches to help support patients with a variety of GI and hepatology problems that we deal with in our division. This afternoon, I'd like to introduce Dr. Suzanne Nelson. Dr. Nelson has been a longtime associate of the GI division here at Lurie Children's, and now she's taken on a full-time faculty position with us, with her practice out at Glenview, incorporated into the Lurie Children's family in a formal way. Dr. Nelson has been practicing for several decades. I don't want to age her too much, but the fact is that she's one of our more experienced gastroenterologists in the program. So without further ado, I'd like to turn over the program to Dr. Nelson.
Thanks, Barry, and thank you, Chad, for arranging this. I'm excited. This is a new way to talk to people, and I was asked to kind of give a 5 to 10 minute talk about some subject. And so I decided to talk about congenital Sucrase-Isomaltase Deficiency because I thought it might be that something that not everybody is familiar with, and something that as a gastroenterologist we consider when we see children in our office. So let me just figure out here how to advance the slides. Next is not working. Chad, do you want to help me figure out how to advance them?
Yep. Do you have an arrow button that you could use when you press?
Yeah, I'm pressing it and it's not moving.
Okay, so then get out of presentation mode and just click on your side screen. So you could just move on if you like.
Let's see here. Oh dear.
It's okay. What I can do is pull up the document that you sent me, and I can move the slides.
Yeah, here we checked it beforehand, but I should have checked trying to how to advance the slides, right? Do you want to take over the screen then, or?
Yes, I'll take over the screen.
Okay.
Give me one moment, please, everybody.
Okay, thank you.
Okay, ready to go.
Okay, perfect. So if you want to show the next slide, thank you. All right, so congenital sucrase-isomaltase deficiency. This is a genetic disorder. It's thought to be autosomal recessive, and it basically is the inability to break down sucrose, and then some people additionally can also not break down maltose. So sucrose is found in fruits and in table sugar, and maltose is found in grains. Next slide, please. So usually the clinical presentation starts when a child is introduced to juice or solid foods, or sometimes even medications that are sweetened with sucrose. And when these are brought into the diet, then the child might have symptoms. And the symptoms can really vary widely in terms of severity. So some people have very mild symptoms, and other people it can be very severe. And part of that just depends on the individual, and part of it depends on the dose of sucrose that they are ingesting. Typical symptoms would include watery diarrhea, bloating, excessive gas, abdominal pain. And so sometimes it might look like celiac disease or lactose intolerance or irritable bowel syndrome. Other times it might present with some nausea or vomiting or reflux type symptoms. And so included in the differential would be dyspepsia. And in more severe cases, it can lead to failure to thrive and malnutrition. Next slide, please. So in terms of the prevalence, it's really unknown because I think it's something that all of us have missed in terms of diagnosing it. There's some suggestion it might be anywhere in people from European descent to be anywhere between 1 in 500 and 1 in 2,000. And it's thought to be very rare in the African American community, and probably also the people of Hispanic origins. It's most prevalent in indigenous populations of Greenland, Alaska, and Canada, where the prevalence can be as high as 1 in 10 or 1 in 30. Next slide. So in terms of the cause, it's thought to be a mutation, and there are many mutations that are possible in the SI gene, and that gene is responsible for the sucrase-isomaltase enzyme. That enzyme is found in the small intestine. Its concentration is highest in the jejunum, but it's throughout the small intestine. And so basically sucrase breaks down glucose and fructose, and maltase breaks down into maltose breaks down into 2 glucose molecules. And so when these simple sugars are, when the disaccharidases are broken down into simple sugars, and they can be absorbed easily into small intestine. However, if they're not able to be broken down, then you have an osmotic effect where fluid and gas then is brought into the small intestine, and that's what causes the symptoms. And so there is, as I mentioned before, a big genetic variation in terms of how much someone might be able to break down sucrose and maltose. And also there are other factors that might play a role. So for example, what the gut motility is like and what other nutritional components are in the diet. And all these things can affect the severity of the presentation. Next slide, please. So the, did we, maybe this is the next slide. So the treatment is, did we miss the diagnosis slide? Can you go back one? Yeah, thanks. So in terms of diagnosing this, the gold standard is considered to be a biopsy of the small intestine. So again, this enzyme is on the villi, but there are things even with the gold standard tests that can make it not accurate. So sometimes you might notice that when we do an upper endoscopy, we look for we'll take a biopsy in the small intestine for disaccharidases, and that will measure lactase, sucrase, glucoamylase, and palatinase. So on people who have sucrose deficiency, the sucrase will be low, or the sucrose will be low. And things though that can make that test not so accurate is that if we put the biopsy specimen on ice, and that's how it's sent to the lab. But if anywhere between when we take that specimen, put it on ice, and when the lab receives it, it goes off of ice, then all the enzymes go away, and it looks like someone's sucrose deficient, and they're not. Another possibility is if the child has another disease where the villi are blunted, like celiac disease or parasite or IBD or something like that, then that could also give you false positive results. Most people that we diagnose with this are diagnosed non-invasively, and we do some type of either a sucrose breath hydrogen test or a sucrose breath test. So the sucrose breath hydrogen test we offer in our Chicago office, and basically what you do is you drink some sucrase, and then every 20 minutes the child will breathe into a bag, and we'll measure the breath hydrogen and breath methane level. And if those levels go up significantly, then the child's considered to have a sucrose intolerance. So there are again false positives and false negatives. It's not 100% accurate test, but it is a non-invasive way of looking for it. But the downside is that the child has to be at the center for a long time, several hours to take the breaths. They have to be willing to drink the sucrose, which is sweet, so most kids like it, but they can't have anything else to eat or drink, and they have to be able to blow into a bag. Another way to do it more recently is is just a plain sucrose breath test. And these, we have home kits in our office. We actually can give them out for free because the company who's developed an enzyme to help with people with sucrose intolerance, of course, wants people to be diagnosed. And so they're willing to give the tests for free. And basically, the child would drink some sucrose at home and then only have to breathe into a bag once. So again, this has false positives and false negatives, but most of the time is an accurate test. And then finally, you can do genetic testing. We don't typically do this because there are up to 10 different, probably over 10 mutations associated with this condition, and we probably don't even know all the mutations. And it's hard to get genetic tests covered, so it would not be the typical way we would diagnose this condition. Okay, next slide. So in terms of treatment, the treatment is basically to restrict sucrose. And so people who are on this diet tend to eat a lot of rice starch and corn starch, since that would be easier for them to digest. And so usually what we do is we start with a relatively strict diet to see, in fact, is our diagnosis correct, and will the child's symptoms improve? And then if they are better, then what we do is we slowly introduce more and more sucrose into the diet and kind of see what their tolerance level is. There are ways that people can get away with eating more sucrose in their diet. One would be if they consumed a small amount of baker's yeast, but we almost never do it because it has such a bad taste that it just doesn't work very well with our patient population. And then there has been, just like there's lactase available, there is an enzyme called Sucrase, which will break down sucrose, and it's a tasteless liquid. It's very easy to give. There is kind of some hoops. It is a prescription medication. There's some hoops you have to go through with the company to be able to get it approved. But we're kind of familiar with that process and have many children who take it and enjoy it because then they're able to have more sucrose in their diet. And the treatment is lifelong. We don't think people outgrow this condition, although it does tend to improve after they're about 3 or 4 years of age. Next slide. So this is a condition, in my opinion, that really requires a team approach. Certainly, as a gastroenterologist, I'm the one who's typically ordering the test and considering the diagnosis and making the diagnosis. However, the nutritionist is a key component of our team. And I do have a nutritionist who sees my patients 1 day a week because I have so many patients who need nutritional counseling. And she's excellent and very familiar with giving instructions both on how to do the diet and then how to do the challenge phase and see what a particular child can tolerate. The nurse in my practice is also a very important part of the team, particularly in trying to get the Sucrase approved and also explaining if they're going to do the breath test at home or if they're in the office for doing that test in the office. And then finally, some kids also benefit from seeing a psychologist, and as well as having a nutritionist in my office. I also have a psychologist who sees just my patients 1 day a week because so many of my GI conditions, there's a big brain-gut interaction. And whenever you limit people's diet, sometimes that's hard, and some kids would benefit from having a psychologist help with that. So that's really it in terms of slides and in terms of talking about what sucrase-isomaltase deficiency is. I'm happy to introduce, take any questions. Before I do that, I just want to make sure that I point out to you how, if you ever need to reach me, you can. And I hope for all of you who have worked with me over the years know that I'm usually pretty accessible. I do have a new phone number, and the phone number to my Glenview office is 312-227-2250. And maybe, Chad, when you send out the emails, you can put that on. I also, of course, have a Lurie's email, which is just snelson@luriechildrens.org. You can also staff message me. I read my staff messages all the time when I'm in my office, Monday through Friday. And yeah, so please feel free to reach me about anything, including this. So should we open it up for questions, Chad?
Yes, absolutely. If there's any questions for Dr. Nelson, feel free to put them in the chat room. I will review them and go ahead and ask them for you. Otherwise, you want to go ahead and introduce Maria?
Absolutely. So you can see Maria there on the line. She is a nurse practitioner who's worked in our division for how many years, Maria?
Almost 20.
Almost 20, yes.
Almost 20.
Yeah, so she sees kids also with us, and for a variety of GI disorders, a very experienced clinician, and it's just been a pure pleasure to have her in the Glenview office. And we're also a good team because you know, we can kind of cross cover for each other. Amanda Wetzel, who's another gastroenterologist, is also in our office, so we have a whole group there, and so we all enjoy working together and helping each other take care of our GI patients.
Maria, would you like to say anything?
Oh, sure, yes. So as Dr. Nelson had pointed out, I've been in GI for almost 20 years. I do go to various locations between Glenview, Northbrook, Arlington Heights, and at the Lincoln Park office. I'm also very accessible and can be contacted by staff messaging in Epic as well as email. My email address is mtmanuel, M-A-N-U-E-L, at Lurie Children's. And then also for feasibility for patients, I also do telemedicine visits as well. And so I would be more than happy to see any of your patients. So thank you for all the past referrals. And I've actually enjoyed working with the GI team for such a long time. And I'm happy that Dr. Nelson is back in our group.
We're happy as well, Maria. This has been great.
Yes. Yes.
Well, like I said, if there's any questions, please feel free to put them in the chat room. Here we go. Hold on. Which patient should this work up? Any age range? So I'm going to go. That's for you, Dr. Nelson, for your presentation.
Sure. So really the age range can be any time between when sucrose is introduced into the diet. So that would be typically when solid foods are introduced or juices are introduced, to really an adult. And so we see kids who are referred who have kind of IBS type symptoms, or maybe kids who have diarrhea and gas and their celiac workup is negative and they don't seem to have inflammatory bowel disease, and that would be a consideration as well.
I hope that answers your question. If there's anything else, feel free to put it in. But like I mentioned, this session is being recorded. I'll be sending it out to you and you can share with your practice. Also, I'll be, as Dr. Nelson and Maria mentioned, I'll be sending their contact information for you so you could have it on record. But I just wanted to say thank you for joining us, and we'll be doing many more of these in the weeks and months to come so you can meet our specialists. But at this time, I'd like to go ahead, Dr. Nelson, please.
And it looks like there was a follow-up question, which I think is a really great point, and I'm really glad
Sure.
They asked it. And that question was, where does the low FODMAP diet come in? And so, as many of you might know, that for people who have IBS, we treat them sometimes with what's called a low FODMAP diet. And so that eliminates certain carbohydrates that might be difficult to digest. The interesting thing about the low FODMAP diet is that it does allow sucrose. And so often before I refer someone to my nutritionist to instruct them on a low FODMAP diet, I'll actually get a sucrose breath test, because then I'll know if that's negative and they have kind of IBS-like symptoms, and a low FODMAP diet will work. Or for example, if someone tried a low FODMAP diet and it didn't work, then it would probably be worth doing a sucrose breath test, because they're not, a low FODMAP diet does allow sucrose. So if you're not doing well on a low FODMAP diet, something to consider would be sucrose deficiency. So yeah, thanks for asking that question. Yeah.
Okay, you're welcome. All right, well, I think this will just about conclude our session if nobody else has any more questions. Okay, I think that's it. Well, again, I wanted to thank Dr. Werschel, Dr. Nelson, and Maria for joining us today. Like I said, we've been looking forward to having more of these sessions in the weeks and months to come. Thank you again, everybody, and have a wonderful day. We'll see you soon.
Thank you.
You're welcome. Bye-bye.
Bye.